for giving me this opportunity. And now I am going to tell you about the molecular classification of endometrial pregnancy in high-income countries. And globally, it is 4,20,000 cases, and mortality being 1.8 per 1 lakh population. In India, up to 2020, it is reported as 16,413. So the incidence is increasing because of the global obesity. So why classification is needed? Because all of you know that there is a traditional and also the new modalities are come into the view of this classification, and so for that we have to take the 3 items into contact, that is called as risk stratification. This depends upon the histotype, grade and stage of the disease, that is Figo staging, and you have to, the classification also needed to predict the risk recurrence, which is the greatest challenge to the gynecologist, and to define the therapeutic approach to know whether who needs the aggressive surgery with the adjuvant therapy or who can be treated with the surgery alone. Next. So classification, traditional classification, first we see the Bachmann's classification has given type 1, which is estrogen related and endometrioid low grade type, and type 2 is high grade, which is estrogen unrelated and non-endometrioid type. The WHO classification is mainly dependent upon the histomorphology. So that later the TCGA classification, which is based on the molecular profile, now we are doing this classification and we are following the treatment aspect. Now this is the histopathology view, the low grade and high grade views. The low grade with the glandular pattern and papillary pattern, and high grade with the diffuse tumor cells. Whereas the non-endometrioid types comes under as a serous, clear cell type, undifferentiated and mixed as usual. So when you are sending the endometrial biopsy for the frozen section, the endometrial biopsy diagnosis you have to look for. When it is high grade endometrioid carcinoma, no intraoperative evaluation is needed. So patient is triaged to lymph node sampling. But when it is of low grade endometrial carcinoma, the intraoperative evaluation is very much needed. When the gross tumor size is less than 2 centimeters or less, the frozen section, there is no question of the full thickness entertainment of the tumor cells, and none of the high grade and no myometrial invasion and also no cervical involvement, then you have to go for the lymph nodal sampling is not required. When the tumor size is more than 2 centimeters and following the myometrial invasion more than 50% with the lymphovascular invasion and cervical involvement, then we need to do the triage to lymph node sampling. So always we have to go and we have to see what is the traditional thing and what are the new modalities. So traditional risk classification especially relied on the histomorphological features, subject to whether it is a high grade tumor or poorly reproducible, and patient could be assigned to the different risk task groups and receive different types of the treatment, and who interprets the slide. So now the TCGA classification, which is a recent one, it come into view from 2013. So addressing that there is inadequacies in the reporting of the histomorphological reporting. So they have entered and they have subdivided as 4 subtypes of molecular classification of endometrial carcinoma with distant or different prognostic levels. Those are the pole mutated, that is called pole ultra mutated, and microsatellite instability hypermutated, that is called as MSIH, and copy number low and copy number high. This is according to the TCGA classification. So based on the TCGA classification, 2 research groups came into view. Those are PROMIS and TransPortec assigned endometrial carcinomas. They are further subdivided as 4 types: pole MIT 1, mismatch repair deficiency, that is called DMMR, and P53 abnormality, and no specific molecular profile, that is called NSMP. So out of these 3, all are belonging to the low copy number, whereas only P53 abnormality is belonging to the CNH, that is copy number high. So we have to use the combination of the NGS, that is next generation sequencing genes, and IH biological profiles and P53 status. So it can be done on the formalin fixed and embedding paraffin blocks, and it is cost effective when compared to the TCGA classification. So that's why we are using this one and we are following the treatment aspect. So what are the advantages of this TCGA or the PROMIS? So they are highly reproducible among the pathologists and high concordance between the preoperative biopsy and final hysterectomy specimens, and high interlaboratory concordance. So if you see the WHO classification, the pole mutant, MMRD and P53 mutation and the NSMP. So excellent prognosis you will come across with the pole mutation, whereas intermediate prognosis with the MMRD, and P53 is very very poor prognosis, whereas NSMP is intermediate risk. Next. So how you are going to diagnose? So once you diagnose with these the molecular classifications, the pole mutant is excellent prognosis, that is 100%, whereas MMRD is intermediate, P53 mutant is poor, whereas NSMP is intermediate to good prognosis. Next. So if you see these diagrams, there are type 1 and type 2 which are intermingled with all the 4 molecular levels. So thick line are indicating the intermingling of these molecular levels with the NSMP, MMRD, pole and NSMP and P53 mutation. So molecular subtypes. What are these pole mutant? Pole mutant is harboring more than 100 mutations and it is characterized as ultra mutant. So it is lead to the upregulation of the inflammatory. Why it is having a good prognosis? So having higher amounts of the cytotoxic T lymphocytes, especially CD3 and CD+, and this Bellon et al. Observed that high T helper lymphocytes are there in the field with the PDL, that is programmed death 1 overexpression. So favorable outcomes may be associated with the high tumor immunogenicity. So that's why please remember the pole mutant will have the high tumor immunogenicity, that's why it is having the good prognosis. Next is the DMMR, that is in this the patient may be with the Lynch syndrome. So 33% are with the increased risk. So whenever the patient with the Lynch syndrome is appearing to you, whenever the patient is presenting with the endometrial carcinoma, as a gynecologist you should not look after only the uterus, you have to go and see whether the GIT is normal or abnormal with the polyposis colon or any other adenocarcinoma anywhere in the body, especially the breast and ovaries also you have to look. So Lynch syndrome type 2 is associated with the less than 3% of the endometrial carcinoma cases and intermediate prognosis. So P53 abnormality, the mutations are less, but the high copy number mutations you will see, that's why the prognosis is very poor and high mortality rate you will come across. So the other one is the no specific molecular profile, that is called NSMP. This is very 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 dangerous. Why? Because it is a heterogeneous group with high recurrence. So that's why you have to take care when the patient is turning with the NSMP and diagnosed by the exclusion of other 3 types. So problematic subtype, as there is no specific biomarker, but the recent biomarker they are evaluated is beta catenin, which is evaluated even in the breast carcinomas. So here it is characterized by high ER and PR expression and expected to be divided into small categories when the new evidence is available. Next. So diagnosis by testing alone the formalin fixed paraffin immediate sections, and pole mutant has no surrogate marker, only NS, that is called next generation sequencing genes we have to do. DMMR requires the ISC staining along with the NSG, that is MLH1 and other things, and MSI1 analysis requires the PCR MSI 5 panel markers, whereas P53 abnormality requires abnormal P53 staining pattern when you do the ISC staining and sequencing with the TP53 alterations. No, next. So treatment traditionally. So always we will have a traditional treatment and a new modalities of treatment. So standard method before introduce the molecular classification, total extrafacial hysterectomy with the bilateral salpingo-oophorectomy, and lymphadenectomy should be considered in patient with the significant risk only. So later the very very recent classification with the 3 members group, that is European Society of Gynecologists and European Society of Radiotherapists and Oncologists, European Society of Pathologists put together, and they have given guidelines for the management of the EC. So with this they have divided as low risk, intermediate and high risk to intermediate. So molecular classification when it is unknown for stage 1A of endometrioid and grade 1 to 2 and LVS negative or focal, you have to go for the same recommendations of that is THS with the BSO, and surgical staging is missing or observation is necessary. Whereas may be considered with the vaginal brachytherapy if LVSI is positive or the patient age is more than 60 years. Same therapy can be implemented when the molecular classification is known, that is stage 1-2 of pole mutation with no residual disease, stage 1A of DDMR with NSMP of low grade, and LVSI is negative. Next is the intermediate risk, the molecular classification when it is unknown. Stage 1B and with grade 1 to LVS negative. Stage 1A endometrioid with grade 3 LVS negative. Stage 1A non-endometrioid without the myometrial invasion. You have to go for the vaginal brachytherapy. Considered observation when the patient age is more than 60 years and no LVS. So same vaginal brachytherapy, and the RT is given when the patient is more than 70 years age, and staging omentectomy should be performed depending upon the LVSI. So molecular classification when it is known for stage 1B with MMRD and with low grade LSIV negative, stage 1A of MMRD, and along with the NSMP you have to go for the same high grade also, you have to give the same therapy. Stage 1A of P50 abnormality of non-endometrioid without the myometrial invasion also, same line of treatment is needed. For high to intermediate risk, when the molecular classification is unknown, stage 1A endometrioid, substantial lymphovascular invasion regardless of the grade depth of invasion, and also stage 1B of endometrioid grade 3, and stage 2 you have to go for the abdominal hysterectomy with the surgical staging, radiotherapy, and EBRT is preferred with the vaginal brachytherapy and systemic therapy. When the molecular levels are known for MMRD and NSP, and with the MMRD and NSMP, and with the MMRD and of stage 2 also same line of treatment when the fertility sparing is not there. Next. When there is an high risk, you have to go for the common treatment recommendations, same line of treatment. Next. So in the advanced cancer, that is stage 3, 4A with the residual disease, and with the molecular classification known with the stage 3, 4A residual disease, no molecular subtype is recognized, then you go for the medically unfit patients for unstable curative surgery, radiotherapy, systemic therapy including the hormonal therapy can be considered. So in the metastatic ones, you have to be stage 4B, along with the molecular classification known or unknown, you have to go for the medically fit patient with the radiotherapy, systemic therapy can be done with including the hormonal therapy. So this is the Transportec and Rainbow Umbrella trial which is going on nowadays as a recent thing. So the aim of these things are to improve the clinical outcomes and reduce the toxicity of unwanted therapies in women with the endometrial carcinoma. By using the molecular directed adjuvant strategies also, they are doing research levels. So 4 clinical trials for patients were included according to the molecular class of the tumor. They have given the rainbow colors, that's why it is called as a Rainbow Umbrella trial. Red trial for P53 abnormality, green for the DMMR, orange for the NSMP, blue trial for the pole mute. So the rainbow trial P53, it is a homologous recombinant deficiency. This is the new modality. It can be present in 50% of the EC cases. HRD, they are doing the work on it. High-grade ovarian carcinomas are also having the HRD and PARP, that is called poly-ADP ribose polymerase inhibitors, which are the standard of the treatment aspect. So trial being conducted comparing the chemotherapy with the DDR, that is DNA damage rejectors, targeting agents with the chemo radiation alone. So hypothesize that 2 years of PARP inhibitors as the maintenance after the chemo radiation will improve the recurrence-free survival rate. So this is the green trial with the DDMR. In this we will see more number of the CD8 T cell infiltration, that's why the immunity level is high. So in this one you have to include the immune checkpoint molecules, that is PDL1 and PDL1 expressed as a counterbalance of the cases for the cellular proliferation. So immune checkpoint inhibitors have shown an objective response rates and they are manageable toxicity. So trial being conducted comparing the radiotherapy with the PDL1 inhibitors or radiotherapy alone. So they are hypothesized that the adjuvant radiotherapy combined with the followed by 1 year immune checkpoint inhibitors will reduce the risk of recurrence. So always you have to think of whether there is a risk recurrence. Then only all these things are come into view. Otherwise if you do surgery, leave the patient without noticing her, they will suffer with the reduced recurrence, which is very, very challenging for the gynecologist. And this is one of the which is very, very dangerous one, because this is endometrioid which is having the high recurrence rate and having the ERPR receptors. So chemotherapy associated with the toxicity. So hormonal, that is progesterone, yield to be the objective response in the clinical trial, and it is comparing the radiotherapy with the hormonal therapy with the chemo radiation. Otherwise the recurrence rate is very high. Next. So the blue is the pole mutant. Here already trial with the 294 patients was done. So no apparent benefit in the clinical outcome from receiving the adjuvant chemotherapy. So 100% recurrence free survival. So when the patient is coming with the report of the pole mutant, you will be very safe because of no recurrence. So omission of the adjuvant therapy is done, only de-escalation is needed in high risk diseases. So this is the POTEC one, giving the chemotherapy or chemotherapy with a DDR or MMRD in all stages with radiotherapy or radiotherapy with a PDL1, and stage 2 and 3 NSMP chemo and with radio or hormonal, and with the pole mutant no adjuvant chemotherapy is needed. Next. So this is the another one which along with the FIGO staging with the invasive procedures of 1 and 3, we have to go for the rainbow chemo and with the chemo radio alone, and with the MMRD with the FIGO 2 LVS 3 we have to go for the radio and with the chemo alone, and with the NSMP again ER positive, so 2 and LVS 1 we have to go for the chemo and with the chemo radiotherapy, and no therapy after the pole mute. Next. So multiple classifier, this is very essential. When you come across the patient with the multiple molecular levels, that is pole with P53, you have to treat it as pole only. DDMR with the P50 abnormality, we have to consider it as a DDMR deficiency only. Pole with the DDMR, we have to treat to classify as pole only. Pole with the DDMR with the P53 abnormality, that is called triple classifier. Information is scarce, it should be considered very cautiously. Now next one. So under the conclusion, the classification, molecular classification of ECs provides a compelling example for how the genomic data can be practicable, accessible, interpretable, informative, actionable, and can be performed at the time of diagnosis and influence all aspects of the EC care. Within this framework, we have the ability to further improve and refine both prognostic and predictive values of this tool. So this is the one when the endometrial carcinoma with the new classification, the genomic molecular testing is very much needed, and also with the combined therapies and with the histopathology analysis, we have to be, should not be too little and should not be too more, and it should be enough. So key take-home messages are, you have practitioners should advocate the molecular testing of EC cases, especially in high-grade or ambiguous tumors, to align treatment strategies with the tumor's biological behavior, to improve the patient outcome, to better understand its relevance in everyday clinical decisions, and to advocate for how it's used in the multidisciplinary treatment planning. So these are the references which are all new. Thank you very much for patience here.
Thank you, madam. Very extensive lecture. For me, it is a Greek and